Hello, everyone. We want to welcome you all to ALS Canada 2024 webinar series. Today, our focus is on medical assistance in dying in Canada. We are joined today by Dr. Wendy Johnston. Dr. Wendy Johnston is a professor of neurology and founder of the ALS Clinic and Research Program at the University of Alberta. Dr. Johnston currently serves on the ALS Canada Board of Directors and is past chair of the Canadian ALS Clinic Research Network. Her research focuses on communication, quality of life, and end-of-life issues in ALS. She has served on expert panels regarding medical assistance in dying, preparedness, and implementation in Alberta and Canada. She has been an invited speaker nationally and internationally on topics pertaining to ALS, MAID, and neurological palliative care, including prior international ALS MND symposiums. Please feel free to put all of your questions in the chat box, and we will be answering all of the questions at the end of the presentation. So to get things started, I would like to introduce Dr. Wendy Johnston.
Hello, and thank you for the invitation. I will now share my screen and try and go to presentation mode. Oops. Okay, there we go. And I'm just going to optimize my screen. So thank you again for the invitation to speak on this important topic. I understand that many people will be joining us from Ontario, and I have to disclose that I am in Alberta, and my on-the-ground knowledge and experience is, of course, in a different province, and that I will go into to some extent why there are provincial differences. So the questions that I felt we were dealing with today are basically, how did we get here? Who is eligible for MAID? How do I, as a patient, get more information, or a family member, or just anyone who's interested? Where does MAID fit in with advanced care planning? Where does MAID happen? And what about organ donation? So as a general outline in this talk, I want to talk about the background of MAID in Canada, how we got here, and that includes legal and medical issues. How do you access information about MAID? Background on motivation for interested MAID, like who's interested, and where MAID fits in with end-of-life planning. So to go back to where we began, this actually dates back several decades to the first Supreme Court challenge when Sue Rodriguez, a patient with ALS, supported by a Right to Die organization, brought a challenge to the law against assistance in dying or assisted suicide, and it went all the way to the Supreme Court. The argument was that the law preventing medical assistance in dying or any assistance in dying deprived a disabled person of the ability to commit suicide, which is not a crime in Canada and hasn't been since 1972. The Supreme Court narrowly ruled against legalizing medical assistance in dying, and so it rested for a number of years. Then the challenge came back in 2012 with the children of Kay Carter and Gloria Taylor. They combined their cases. So Kay Carter is up here on the left. Can you see my arrow? Could someone from ALS Canada let me know if I move my arrow around, you could see it?
Yes, we can.
Perfect. So this is Kay Carter. Kay Carter did not wait for the as you can see, it's very slow. For the legislation to go through. She did travel to Switzerland to seek doctor-assisted suicide in 2010. Gloria Taylor, however, had ALS, and it went through the BC courts, and it was first of all passed, then challenged, and then taken to the Supreme Court of Canada. So this takes many years, and Gloria Taylor actually was granted a constitutional exemption to seek assisted suicide, but she died of a complication, not necessarily of ALS, but she died without acting on her constitutional exemption. So in 2015, the Supreme Court of Canada, this is a copy of the official document, ruled on the appeal. And they ruled that in Carter versus Canada, that in very legal language, which I'm not going to read verbatim, that basically it was against the Constitution to criminalize medical assistance in dying, because taking one's life is not illegal in Canada. Assisting or advising someone to take their life has been. But because taking one's own life is legal, those who are prevented by illness or injury or an underlying condition who don't have the agency to take their life are therefore deprived of that ability. And so that is felt to push people, for example, a person with ALS, to consider taking their own life prematurely. And thus, ironically, medical assistance in dying is felt to uh, support people to a right to life. And under the Constitution, we have a right to life, liberty, and security of the person. So it was under this interpretation of our constitutional law that the Supreme Court ruled that um, making it illegal, making it a criminal offense for a medical practitioner to support a patient in dying was unconstitutional. There were limits set so that this was limited to those that had grievous and irremediable medical condition, and that this right to medical care to assist in death was critical to dignity and autonomy. So that gets back to the security of the person. So to further go into the actual law, so the laws prohibiting physicians' assistance in terminating life infringed on Ms. Taylor's rights to life, liberty, and security of person. It was not in accordance with the principles of fundamental justice. And in this, Canada differs from the many countries worldwide that it's felt to be unconstitutional to deprive an individual, a physician or nurse practitioner support in hastening death. So they basically said to the government, you've got to take this out of the criminal code. So that led to some scrambling on the part of the government. And Bill C-14 came into final reading in May of 2016. So it took about a year, so it doesn't happen immediately. And they ruled that in law, a competent adult with a grievous and irremediable medical condition who's suffering intolerably and where death is reasonably foreseeable must voluntarily request and provide consent with 10 clear days between formal request and provision. So the interval of contemplation was part of the law. And furthermore, that the individual seeking assistance must be eligible for funded health services delivered by a Canadian jurisdiction. So this effectively ruled out medical tourism, such as been experienced in Switzerland. So in Alberta, the medical college came up with advice to patients so that people who are interested in medical assistance dying understood at that time that you have to have a serious illness, you have to be in an advanced state, can't be reversed. You must be suffering unbearably. And I have to note that suffering is a personal construct, so that I, as a doctor, can't tell you about your suffering. Only the person with experiencing suffering can say whether it's unbearable. And then at that time, death had to be reasonably foreseeable. It didn't have to be a terminal illness. So you didn't have to have a terminal illness, but you had to have a reasonably foreseeable death. So for example, someone who met the above criteria, had advanced age and multiple medical conditions, might be viewed as having a reasonably foreseeable death. However, not surprisingly, because the Supreme Court did not tie this to actual reasonably foreseeable death, that was the government legislation that dictated that. There was naturally a challenge to this aspect of the law, and the reasonable foreseeability of natural death was deemed to be unconstitutional itself. So it came back around to the government to pass a new law, and Bill C-7 spent over a year wending its way through the various prorogations and limitations imposed by COVID to be passed on March 17th, 2021. And so Bill C-7 is the law that currently covers medical assistance in dying in Canada. And it actually has two tracks. For those with a reasonably foreseeable death, that they eliminated the 10-day period of contemplation. They required only one witness for signatures. And some of this was brought about because of difficulties in the pandemic. The two exceptions were made to the requirement for final consent at the time of the MAID procedure. There's an advance consent arrangement for those who have been able to consent to MAID, such that on the day that MAID is provided, they don't have to provide the final consent. This was very key because individuals who sought MAID were declining symptomatic therapies because they did not want to be viewed as having clouded judgment or being incapable of providing consent. So someone who's initiated the MAID process, who's clearly consented, but has not yet set a date, or the date is days or weeks away, would not be denied MAID because on the day that that it comes to pass, they are not completely with it, shall we say. They're not completely capable of providing the final consent. So this is not the same as someone having an advance directive indicating that they would like to have MAID at some future time. So that is still unclear in Canada. But currently, for example, someone who's experiencing progressive dementia, it's not clear that they can pre-consent to an unknown date at an unknown time. So this only applies to an individual who's already consented to MAID, started the process, had two assessments, but may on the actual day of provision lost some capacity. And then the second exception is in the rare case in Canada where a patient has elected to do self-administration, that is to take a lethal cocktail of drugs. Sometimes we know from our experience in other jurisdictions, for example, Oregon in the US, that sometimes the oral route fails. And so the exception provides that the physician does not have to wait for the patient to wake up to obtain consent. They can take the prior consent and complete medical assistance in dying the intravenous route. This comes up very, very infrequent. I would say it hasn't come up in my knowledge because almost exclusively MAID is being provided with intravenous access. So one of the big changes in the MAID legislation was providing a track, which is called Track 2, at least in Alberta, that does not require a reasonably foreseeable death. So this Track 2 has additional safeguards. It is a longer assessment period. So someone who has a reasonably foreseeable death is hastening their death. Someone who does not have a reasonably foreseeable death is seeking MAID due to unbearable suffering of an irremediable condition. But because they don't have a foreseeable death, a minimum 90-day assessment period is put in place. And there has to be a second eligibility assessment by a practitioner with expertise in the condition that is causing the person's suffering. This is very relevant to neurological disorders because not all neurologic disorders that are progressive and cause irremediable suffering they may not have a reasonably foreseeable death. So these are two important provisions that have opened the door for MAID to people with chronic conditions rather than those who have potentially life-threatening conditions. The other change, that's not a change, but clarification, was at that time MAID was not going to be made available to those whose sole underlying medical condition is mental illness. There are other provisions that there was a greater onus on showing that the counseling service, mental and disability support was provided, and that the suffering had been addressed by a practitioner or practitioners with skills and knowledge in the area of their condition. So to summarize, suicide is legal in Canada and has been since 1972, but counseling or assisting another individual to complete suicide has been a crime in that time. That is why those who undertake what might be viewed as a rational suicide can't involve family, can't have family at their bedside, and can't seek assistance from a medical practitioner. Physicians and nurses are now, nurse practitioners are now exempted by federal law from prosecution. However, medical care is a provincial jurisdiction. So the Supreme Court ruling and the federal legislation only lifted the criminality of providing the care. The actual practice is under provincial jurisdiction. And so that leads to a variability in communication to some variability in how it is practiced, and that makes it more difficult for someone like myself giving a national talk to know all the circumstances and details in each province or territory. So, in my experience, what has happened is MAID um, was viewed as a medical procedure with uh, all the medical responsibility to uh, do this effectively. So failure would be regarded as a failure of medical practice, just like a failed surgery would be. And so the actual advice to the profession was then given to the provincially legislated bodies known as the colleges. So it's the College of Physicians and Surgeons of Ontario, the College of Physicians and Surgeons of Alberta. So each of these and have an assigned responsibility and detailed regulations that govern the practice of the individual physicians. Similarly, nurse practitioners have their own college that regulates their work. So this is a busy slide which just shows how each province or territory has their own guidance, and there's a lot of similarities between each province. Um, all of them really start with discussing end of life care and end of life options with a healthcare provider. All of them have some degree of paperwork involved, and there's variability in the process in how centralized or decentralized it is. Um, just to summarize with a different cartoon, all the provinces and territories, basically, if you look at the healthcare websites, say contact your healthcare provider. A number of provinces have a MAID team. So in my experience in Alberta, we have MAID teams that I can refer a patient to, I can refer family members to, a physician or nurse practitioner for whom MAID is not a topic that they feel they can comfortably discuss, they can make the referral to the MAID team. The MAID team is not charged with only providing medical assistance in dying. They are tasked with seeking to know what the irremediable suffering is, and to see if there's anything that can mitigate this. In my experience discussing this with the MAID team locally, often patients are really needing to be referred to palliative care. They're needing to be referred to services. So their questions about MAID have been the entree to finding out where other services can be met, to continue living with their condition and perhaps relieve some of the suffering and burden of their condition. Some provinces, however, strictly go to the provider, and that creates maybe some barriers to accessing MAID. If you're in a low population area and your provider is not comfortable with referring patients. And so there's still some conflict that may arise in the context of having to only discuss this with a provider, and the relationship between a patient and provider being the key to moving on in a good communication uh, way to meet the needs of the individual. And the needs may be related to seeking information about MAID and seeking to know how to proceed, or it may be, what's MAID, what's more than MAID, what else can I do? So that's something to be aware of, that you may need to look at other resources if your healthcare provider locally is not being supportive or conducive to outside referral. So if we take a step back and say, why would someone seek MAID? So under the law, it seems very clear, and certainly in a lot of the coverage, the media coverage of MAID, a lot has been focused on people who have very advanced disease, who are suffering, and who are not getting the relief they need from the usual medical interventions. However, there are motivations for seeking and completing assisted death that are not related to the condition or the physical manifestations, such as pain and suffering. So additional factors are a sense of independence and self-reliance that has been lifelong. So these are factors of the individual. People who have low spirituality, who don't identify with an active religious practice, also are more likely to be interested in assisted death. Fear of future suffering is very important. And in the literature around people with ALS and their motivation, the fear of future suffering tends to be the dominant source of suffering rather than an immediate suffering, as is often portrayed in the media, for example, with cancer patients and intractable pain. Most studies were retrospective, with interviews of caregivers, or prospective and looked at motivation, but rather not completion. In addition to low spirituality, a sense of loss of hope was also a factor that was important in the motivation or related to people's motivation for seeking information, or seeking to have assisted death. So there's one prospective study in Oregon that looked at those who sought assisted and completed assisted death and controls, those who were not interested. And that's where the fear of future suffering was really confirmed as a major motivation. Personal characteristics of the individual rather than characteristics of their condition tended to dominate. But in this study, it appeared that depression and hopelessness, that is, hopelessness that's not associated with depression, seemed to be higher in those who were interested in seeking and completing assisted death than those who did not. So people who are more hopeful, people who do not have mood disorders, are more likely to not seek assisted death. So this is a cartoon that I've used to talk to doctors about this, that someone who's seeking to control even their execution by firing squad. So it says he's a very controlling person. So the captain of industry is another way I put it. People who are wanting to be in charge, who be in charge, they want to continue to manage the manner and setting of their death. So medical assistance in dying is unique in Canada in that we had sweeping national legislation after the Supreme Court ruling. And this was something that the medical profession started to prepare for. There was a lot of intense work, particularly in the year after the Supreme Court ruling leading up to the law. And this differs from other countries. So, for example, the Netherlands has had a medical practice and a cultural acceptance of medical assistance in dying that actually predated its legalization. We in Canada had not had a practice of providing hastened death, with it was in a way that was viewed as acceptable, but was not probably entirely legal. So we had an entire country that had to make quite a few adjustments very quickly. So one of the things that's become evident is that neurologic cases are that prompted the law also continue to be more representative, more represented than proportionally than other conditions. So neurologic causes of death in Canada are less than cancer deaths and less than cardiovascular deaths, stroke and heart disease. But proportionately, the number of people with a progressive neurologic disorder who seek MAID is higher. And that's come up every year in the national reporting. So provincial reporting is yearly, and they in turn provide their data to the national report. The last report that was available for review was in October of 2022, and we're just about due for the report from this for 2023. We see that ALS, multiple sclerosis, and Parkinson's disease are represented within neurologic diseases as proportionally more likely to seek medical assistance in dying. So when is the right time to discuss death and dying? In this cartoon, we say only Alan was prepared to acknowledge the elephant in the room. In medical care, in palliative care, we often refer to the likelihood or the risk of dying as the elephant in the room. And so in this instance, I think Alan may be the one who's under the elephant. So people may not be talking about it, but it's often on people's minds, particularly if they've been told they have an illness that will result in death or a condition that progresses to death. They may have that on their mind, but they may not be speaking out about it. So in general, questions about MAID can come up at any time. I find that it can come up at the time of diagnosis, and this may well reflect, again, the individual characteristics of a patient. It may reflect their awareness of media coverage of the original Supreme Court ruling. It may reflect their own fears around loss of control with a disabling progressive condition. It can occur at the time of the first dip in health. For example, someone might develop pneumonia, and at that time coming to hospital, they may, in concern of future suffering, perhaps reflecting their current symptom burden, ask about MAID. Or it may happen well towards the end when someone perceives that they are going to be their life end of life is approaching, and again they don't want to lose control. They want to be in charge of their medical care and the timing of death. There's also tremendous concern that is promoted by media coverage of certain symptoms. Like, it's still out there that that people will say, or it'll be in an article, that ALS patients will choke to death. And if you are experiencing breathlessness, if you're experiencing trouble with swallowing, then the fear of choking to death really drives a discussion around medical assistance in dying, around advanced care planning. So we have to talk about the differences between asking about MAID and advanced care planning in general. So in Alberta, we have very clear communication province-wide about what each of these designations are. So advanced care planning is what you and your loved ones talk about before you get to end of life. It's something that we do at the time of making our wills, for example. It may happen in the setting of a known surgery coming up, that you know there's a major surgery and you have opinions about the medical care that you want. So advanced care planning is very much about thinking ahead, asking yourself what you would want done in certain circumstances, and most importantly, communicating that to your loved ones and to healthcare professionals. In many jurisdictions, there are variations of what we call goals of care designation. You may be familiar with the term DNR, or do not resuscitate. That is the most basic and sort of archaic way of referring to that. So basically, with a do not resuscitate order, if your heart stops, the do not resuscitate says, don't start it, don't attempt to start it. It becomes a little fuzzier when certain downturns in medical situations may not be the binary between living and dying. And so at what point do you invoke a do not resuscitate if someone is experiencing progressive respiratory failure, if their breathing is getting weaker and weaker? Does a DNR order say, no, I don't want to be put on life support? So the simple DNR is not sufficient to guide healthcare providers or to guide your loved ones in what you would like to have done. So in Alberta, the goals of care designation break things down very particularly into resuscitative care, which is ICU care, to medical care, which is care provided in a hospital, to comfort care, which is that can be provided anywhere, but overall with a desire to remain in your own home or location of habitation. So advanced care planning conversations don't always result in a goals of care designation, but these are all building blocks towards discussing what you'd like done in the event of a downturn of your health. And I think the practice of talking about what you would like is important, because you don't want it to be a hallway conversation when an immediate decision is required. So I want to clarify at this time that the right to refuse treatment is not medical assistance in dying. The right to refuse treatment has been enshrined in Canadian law for 30 years. I think 30 years, if I'm doing the math right. And so this is a series of challenges that dictated that people can say no, even if it doesn't seem like the right thing to do. So if a competent individual decides not to have a treatment, they have the right to refuse treatment, even if it seems like a bad idea. There are exceptions where the treating physician may feel like the person is making the refusal based on misinformation, or but they can't override a patient's interests. It's only if there is determination of loss of capacity that a refusal of treatment could be taking place. That's why it's so important to have your advanced care plan, because if you lose capacity, if I lose capacity, I have in my advanced care plan and my legal representation indicated that my husband, for example, can make the decision for me. He can represent my interests so that the right to refuse treatment can be transferred in the case of a loss of capacity to a designated individual. So that's all part of the advanced care plan, is to make sure that your wishes are ultimately respected by the medical system. So just to go on about what MAID is or isn't, and unfortunately I don't have a clock in front of me. Okay, we're good. Um, so MAID is a medically controlled death under the direct care of a medical professional. So while it wasn't dictated by the Supreme Court or by the government of Canada, the individual colleges determined that a medical professional has to be present at the time of death. So this has pushed very much the provision of MAID to the intravenous um, provision of medication to sedate and ultimately freeze the muscles of an individual, causing death. So, unlike other places in the world, all the US states that have passed medical assistance in dying law, in those jurisdictions, the medical professional gives what we call a lethal prescription. So, they give a prescription, the individual obtains the medication, and they self administer. Almost all the time in Canada, a medical professional is actually delivering the medication, usually intravenously. So in Canada, only the person receiving MAID can request it. You can't request it on behalf of someone else. Advanced directives designating that are still being worked out as to whether that can be done, for example, with um, people in early dementia, designating someone to request MAID at a certain point. That is not entirely clear. And of course, the person receiving MAID can request it, but doesn't necessarily have to have capacity on the day of MAID. MAID requires the involvement of at least 2 healthcare professionals, an assessor, and a provider. And we have to fill in multi-page forms. And these are reported to the government, and these are reported to our college. The MAID process can be expedited. For example, the 10-day waiting period has actually been always somewhat flexible, but for those with a reasonably foreseeable death, there is no 10-day waiting period. And the MAID process can be expedited, but nonetheless, it is a multi-step process requiring 2 assessors and submission of forms. The individual requesting MAID has to do their own form. The assessor and provider have to do their own forms. And this can take place over a shorter period over several days. It is not the answer to immediate suffering. So someone who's developed immediate suffering, that they need care in the moment. So MAID is not palliative care, and MAID providers are not necessarily palliative care physicians, but those receiving palliative care may request and complete MAID. So they are not oppositional. They're not one or the other. And the majority of people who complete MAID have had access to palliative care and received palliative care. The timing of MAID is a personal choice. Unlike a natural death, which there's some uncertainty about, timing of MAID does allow the control to set a date and work with medical professionals to complete this. So symptom burden may be a reason for MAID. Intolerable suffering can be due to symptom burden, whether it's pain or breathlessness. But usually the symptoms are treated by primary care, by a multidisciplinary team, or palliative care and hospice all the time. And so you should not be holding back from seeking support for your symptoms. You should not be thinking that you have to choose between symptom support and treatment and MAID. They all can be delivered concurrently. Someone may be initiating the MAID process while at the same time be titrated up on medications to control their symptoms. So this is not oppositional. So most patients actually don't complete MAID, but the availability of MAID is reassuring to many. So I think that open discussions about medical assistance in dying are very conducive to further discussions about what end of life care can look like and how this should be delivered in the choice of the person who's contemplating it. So we also have to be clear that completing a request for MAID is a different administrative pathway from completing goals of care. And goals of care and advanced care planning are their own thing. So you may be including MAID as part of your advanced care planning. You may indicate in your goals of care that at some point you'll be seeking MAID, but completing a request for MAID actually doesn't move you along in advanced care planning or in informing your family or medical system around your goals of care. We have had patients who are interested in and ultimately complete MAID who have sought medical support in the interim, even life-sustaining support such as non-invasive ventilation. So specifying wishes for resuscitation, hospitalization, and medical care is really important because if you don't make these goals of care clear, you might end up being resuscitated when in fact you're seeking MAID because you feel that your life is coming to an end. So while these are separate administrative processes, the application for MAID, doing your goals of care or setting the local requirements for what you wish in terms of medical care, you need to be clear that if you're accepting and thinking that you don't wish to continue living, then being resuscitated is not really what you want. But you have to make that clear to your providers. And in general, while MAID can be expedited for acute suffering, there's really a need to provide the care for acute suffering on the spot. And if acute suffering is such that palliative sedation may be indicated, that can take place. Now, palliative sedation can be offered without an application process. It's a medical decision that's taken by a medical practitioner in the setting of treating a patient that they know or they've come to know in acute situation. So palliative sedation is an alternative to medical assistance in dying to deal with acute and irremediable suffering when the legal process may be overwhelming. So how do you discuss MAID with your medical practitioner? That's a toughie. And if in these days when so many people don't have a primary care doctor, you're in a situation, perhaps in an emergency department or a walk-in clinic, where you're introducing the topic to someone you don't know well and they don't know you. So you can present it as, I'd like to know more. Can you talk to me about it? Can you point me to resources that would explain how I can access it? And physicians have to have a response. They can't just turn around and walk out of the room. They can't say, nope, I don't do that. They are required to at least point you to resources, to send you out to the desk to say, Mrs. So-and-so will give you the form, give you the brochure that'll explain how you access it. Physicians may, and I hope they may think that this is the foray in discussing about advanced care planning, goals of care, or concerns about dying. So certainly that's how I view this. If someone asks about MAID, I say, MAID is something that is legal and patients with ALS are certainly eligible, but let's talk about the overall picture where this fits in to your, ongoing quality of life and what you see at the end of life. We should always think about concerns that underline the request and view this request to discuss MAID as an opening rather than as a first step to actively pursue MAID. Since many people will bring up MAID as part of their initial adjustment to ALS or at the time of a first illness, the interest in MAID may come months and years ahead of any actual end of life decision making. So one of the concerns I have in Canada is that people with ALS have been associated with MAID, and to a doctor who's not as familiar with ALS, they may feel that expressive interest in MAID is a request to proceed with MAID. And I think that I'm hoping to empower you to consider that MAID is part of end of life discussion, and it's it's an alternative at end of life. It is one of our choices, and MAID was promoted as increasing our choice in dying. but we can't view MAID as the only way to die. And it's not always necessarily the best way to die. Whether you can have a good death with a natural death is something that you should be discussing with your providers. So each physician has to come up with a response, but you also need to know that no physician is required to either be an assessor or a provider for MAID. A physician who does not provide information can be reported, but they are not on any obligation to take this further in terms of doing the assessment or provision. I wanted to put a word in for organ donation. Organ donation has come to be possible after a great deal of discussion in a national summit. Previously, ALS patients were not considered eligible to donate solid organs because the cause of ALS remains, well, increasingly better understood, not completely understood, and an infectious cause has been a very remote, I have to say, very remote possibility. So it was determined that this was such a remote possibility that ALS patients may be eligible to donate solid organs based on the same parameters that any other individual may be considered. So heart, kidney, solid organs can be donated, excuse me, and organ donation may be coordinated with MAID. I know that in Alberta, if you choose to have medical assistance in dying at home, we can't coordinate organ donation with a home death, but we can coordinate organ donation with a death in hospital. And we've done this a number of times. I understand that in Ontario, in certain places, even a home death may be coordinated with organ donation. So again, another topic to talk about as you look ahead to planning your choices at end of life. I also want to put a word in for brain and spinal cord donation for research. We really benefit in research from those wonderful people who donate their brain and spinal cord. Increasingly, research is being done with patient donations to advance our understanding and to advance our ability to assess new therapies for ALS. So in general, the choice to do organ donation may impact the timing and place of death, but it needs to be discussed with your MAID provider if you're going with MAID, and with your local hospital and medical system. And I understand that organ donation will be the subject of a future ALS Canada webinar. So in conclusion, Canadians have a right to healthcare, and not so much a right to MAID, but MAID is considered a part of healthcare. So I can say in a kind of convoluted way that MAID is a part of our healthcare, and you can have an expectation of accessing this. Navigating the process can be daunting, and having a clearinghouse of information and coordination has been very helpful, certainly in my experience. MAID is an end-of-life choice and should be seen as part of end-of-life planning. It's not the only death, and it's not necessarily the best death. So for some individuals, it is the best death that they can plan, but you can have a natural death that is a good death as well, and that's subject to discussion and planning on the part of you and your medical professional. So end-of-life planning is more than requesting information and applying for MAID. It should also include specific instructions about goals of care and plans to access support such as palliative care. So I will stop sharing my screen. And I believe, Emily, are you moderating?
I believe Melissa is going to go over some of the questions that were submitted, and so I'll hand this over to Melissa.
Thank you. So your presentation was very detailed, so it did answer some of the questions that originally came in, but we do have a couple. So the first question is from Sandra, and it's asking, how does a power of attorney impact the advanced care planning part?
So advanced care planning is around medical decision making, and a power of attorney is invoked. So if you've gone and been done your homework and done your will and power of attorney, then you've designated someone who can make financial and or legal medical decisions for you in the event of loss of capacity. So the power of attorney really only is invoked if you can't speak for yourself.
Okay, thank you very much. Another question came in, how early can someone apply for MAID? And how early can someone do MAID?
So that is a good question. So many people apply for MAID or almost do the initial registration early after diagnosis. I would suggest that early after diagnosis is not a good time because of the shock and the uh, perhaps an inability to see yourself as a person with ALS. And so we have not come up with firm guidelines in the ALS community about how early is too early. But currently, we are not in a position to stand in anyone's way. I would have concerns about someone who seeks MAID within weeks or months of a diagnosis, and it would be something I would frankly discuss with them if they were my patient. At the moment, there is no barrier. For example, no one's going to come in and say, "No, no, no, you're track 2, you have to wait 3 months." So I worry that those who are adjusting to ALS, who have are working out how they're going to be supported, who may feel alone in dealing with this disease, may view MAID as the only reasonable alternative. But I would hope that the practitioners to whom they uh, discuss this, with whom they discuss this, would seek the support of health charities like ALS Canada and the provincial ALS societies, would seek the support of a multidisciplinary clinic to ensure that a patient diagnosed with ALS has seen and understood all the resources and can make a decision that is not impulsive or reflecting too much hopelessness about what can be a very difficult condition. Was I clear enough?
Yes, very clear. Thank you. The other question, another question from Angela, it says, do ALS patients have to wait the 90 days?
No. So ALS patients are on the whole regarded as track 1, the original track, and so really have the ability to request and complete MAID within days if they so desire. So that's what I was kind of alluding to in the last statement, that they, as you may know, people with ALS have varying prognoses. And when you look at a website or you look at the stats, they generally quote something as 2 to 3 years. Well, we know that 1 in 5 persons with ALS live 5 years or longer, and 1 in 10 live more than 10 years. That's one of the things that kind of slows me down when I think about people who are recently diagnosed seeking MAID at that time, because early on, we're still figuring out which trajectory you may be on. There may be aspects of ALS that are not reflected in an individual's assessment of its progression that influence their desire for MAID. So in general, I would say no practitioner views an ALS patient as not being eligible for track 1, or would it dictate that they need to be put into track 2 with the 90 days. If you run into that, again, I think a multidisciplinary clinic might have a more nuanced interpretation and support you in your own timelines.
Okay, so Angela is now responding. She originally asked that question, and she is saying one of our assessors indicated there is a 90-day waiting period. Is there a reference to this somewhere? My husband still needs to see the second assessor.
So it sounds to me, Angela, like somebody has viewed your husband as not having a reasonably foreseeable death. And so they have placed you on track 2, and that's why you're having 2 assessors, and presumably a separate one of the assessors is a provider, or you have a separate provider. So without going into, and I shouldn't know any more about the circumstances, it seems that someone in there has decided that your husband does not have a reasonably foreseeable death, and that's something you could challenge the assessor on. If that's a source of distress for you and your husband, that you're being placed on this 90-day trajectory. And not knowing where you are, this is something you may want to talk to your local health ALS health charity about. There is also, and it was referenced in one of the slides, there are a number of organizations who are promoting medical assistance in dying, who've been active in supporting the legislation and disseminating information. And you can actually, I'm not sure if you're locally, there's anyone that can support you in communicating around this, but there are definitely advocates out there, Death with Dignity being one, where you might find an ally to help you navigate this difficult situation.
Thank you. Okay, we have lots of questions coming in. From a logistical perspective, where does MAID take place?
So again, I'm talking across Canada, right? So I'm aware, for example, in Yukon, someone did self-administer because they didn't have a provider to, and they could do the provision with an intravenous. So there are obviously local variations, but in most urban centers, MAID can be provided in a medical facility, and increasingly in a home, in the home. Now, whether it can take place in your usual place of residence might be dictated by the rules if you're in a long-term care facility, or particularly if you're in a facility that is a religious background. So, for example, a lot of across Canada, Catholic services are in charge of a number of long-term care facilities and hospices, and provision of MAID in those circumstances would have to take place outside the facility. For example, someone may go home, living in supportive living, they may go home to their family's home for the provision of MAID, or they may go to a local hospital. Non-denominational hospices do support MAID, but it's up to the individual hospice to make that decision. So it's all of the above.
Thank you. Another question coming in is, how is consent for MAID given at the time of the procedure if someone is not able to communicate? Do people accept eye gazer as a form of communication and consent?
This is one of the reasons people with ALS often seek to initiate the MAID process well in advance of when they want to use it, because they want to do the assessments and meet their assessors and the provider while they're still able to communicate more easily. Now, if you're using eye gaze and you are if you're using eye gaze and you're not having respiratory support such as a ventilator, again, working with an individual provider, if they have been trained to work with you on eye gaze, it is, as long as you're deemed to have capacity, then you can proceed based on the established communication pathways. But if you're on 24-hour invasive or non-invasive ventilation, you do have the option of having palliative sedation rather than MAID. There's still a need to communicate, but the onus is not quite so legalistic.
Thank you. Another question is, can you explain the medicine, i.e. process of the administration of MAID itself? So what actually happens?
So I am not a provider, so I have not completed MAID with a person who wishes MAID. So I understand that it's typically 3 medicines, 2 strong sedatives, and then a medicine that stops the contraction of muscle. So stops the heart and voluntary muscle. So they're given in succession. Anecdotally, I have understood that sometimes the deep sedation is such that the patient dies after the deep sedation. So it's typically 3 drugs. I'm not currently familiar with what the drug cocktail is in the rare circumstances where it's an oral, where someone takes it orally, because that's done so seldom. I just don't know which drugs are still used. It's quite a cocktail though. Like it's a volume, it's a lot to drink.
Okay, thank you. Another question, is MAID considered suicide in relation to faith? Is it a sin to do MAID?
So that depends on your faith. And if you are active in your faith, you need to discuss this with your spiritual provider. So certain religions make it very clear that medical assistance in dying is not consistent with being active in the faith. So the Roman Catholic Church, for example, is very much opposed to medical assistance in dying. So I think that if you're active in your faith, you do need to talk to a spiritual provider. I'm aware of the Roman Catholic uh, view because there's this interaction with certain care facilities. And so I can't speak to, for example, an individual Buddhist practice. And within different faiths, there can be variations. And so, for example, if I understand that within Orthodox Judaism, MAID is not acceptable. So ultimately, you do need to discuss this with your spiritual provider.
Thank you. Is MAID considered a type of suicide that can void your life insurance?
No, because MAID is clearly designated as a medical act. It is not viewed as suicide.
Okay, another question is, are there conditions where patients can be relieved of their pain at end of life? Or is medical science able to control all pain for all conditions?
So, in general, nothing in medicine is 100%. And the control of pain is something that we have a high success rate with, but pain is complex. And so pain is often viewed as purely physical, but pain is amplified by other factors related to loss, related to other sources of suffering, so that relieving all pain for some individuals can be very difficult. One of the impetuses for medical assistance in dying is the knowledge that there is some pain, some people experiencing pain that is not relieved, or it's not relieved in a way that's acceptable. And so you can relieve pain by putting someone to sleep. You can relieve pain, even whole person pain, with palliative sedation. But the individual may not view that as acceptable. Pain treatment can result in some instances, in sedation. So someone just feels like they're knocked off all the time, and that is not acceptable. So living with controlled pain may still be a circumstance that that is giving that person intolerable suffering despite the pain being managed. So I think pain is always approachable, but there are patients in pain for whom there isn't an acceptable medical management to them that renders their life worth living.
Thank you. And the last question we have is there an age limit with MAID? Can someone under the age of 16 or 18 apply for MAID if they have a terminal illness?
Currently, 18 is the cutoff.
Okay, thank you. That is all the questions I have for today.
That's all the questions. Okay. Well, thank you for your attention, everyone. If there's any last minute, we have 2 minutes. I'll stay on if there's any burning questions that people are just having trouble typing into. Is it through the chat that you're getting the questions?
Yes, that's correct. People are very thankful and say that the webinar was extremely detail oriented, and thank you.
Good. Well, future webinars may need to be more on a provincial basis so that the guidance around navigation within a particular province or jurisdiction can be even more detailed.
No, absolutely. And we want to, on behalf of ALS Canada, we want to thank you, Dr. Johnson, for participating and for sharing all of your knowledge about this topic. It comes up on a very regular basis with us as community leads and with the clients that we work with in the community. So we do appreciate that. It's been an amazing question and answer period also. I know that always gives a lot of information, so it's very much appreciated. And so to everybody on the call, we will have this session's recording up on ALS Canada's website under our resources page, as well as on our YouTube page to be able to watch back. If there are any additional questions, please don't hesitate to reach out to communityservices@als.ca, or if you are connected with the ALS Society of Canada, please connect to your community lead and they'll be able to answer some more detailed questions and be able to navigate things that may come up. And for individuals that are outside of Ontario, please connect with your ALS Society or connect with your healthcare provider. They'll be able to point you in the right direction. So if there's any questions, please don't hesitate to reach out to ALS Canada. I appreciate everybody taking the time to join in the webinar today, and I hope you have a great rest of your day. Thank you, everyone.
Bye-bye.
Bye, thank you.